we have Dr. Ajam Jamali giving us a talk.
I would like to start with a case that happened about 10 years ago when I was in Wisconsin. It was a 50-year-old or so gentleman, kidney transplant recipient on maintenance immunosuppression with mycophenolate and prednisone, presented with a rising serum creatinine over time, checked his antibodies and determined that he had durable DSA of class 2 around 20,000, so high MFI levels, at least at our institution. We did a biopsy, didn't really show much interstitial inflammation, tubulitis, arteritis, but had mild glomerulitis, peritubular capillaritis, microvascular inflammation score of 2, moderate C4D staining, minimal hyalinosis, but advanced or severe transplant glomerulopathy, and some mild chronic interstitial fibrosis and tubular atrophy for an overall chronicity score of 5. We didn't really know what to do. And at that stage, the overall thought was, okay, maybe just optimize baseline immunosuppression, which is what we did. His mycophenolate, which was at 360 twice a day, was increased to full dose. And we reintroduced tacrolimus, which was originally added because it was thought that it was going to be nephrotoxic. But unfortunately, what happened is that this gentleman lost his allograft about a year after that biopsy. So what we are going to talk about today is what I call the triple aim for kidney transplantation. I don't think that anyone would argue that if we could achieve this goal, we would really achieve or reach the holy grail in transplantation. People talk about the holy grail being tolerance, but I'm not as optimistic or as ambitious. I would say if we can achieve the goal of 1 kidney transplant for life, optimal immunosuppression, that is no rejection, but of course, no infections, no cancer. So in other words, precision medicine, and no kidney allograft biopsy in a scenario where we don't have to really proceed with invasive processes, that would be a huge achievement. With that in mind, let's move forward and determine what is really antibody-mediated rejection. The terminology is quite specific, and it includes antibodies, so antibodies here, that mediate rejection. This rejection can be either direct through antigen-antibody interactions. These antigens are primarily HLA peptides that are presented on the surface of endothelial cells. So a direct pathway, activation of the endothelial cell, resulting in cell proliferation and ending in fibrosis if the repair process is not appropriate, or through an indirect pathway. The indirect pathway will require either the complement, hence the deposition of C4D as a footprint of rejection, or it will be complement independent. And this is a process in which you have peritubular capillaritis or glomerulitis through recruitment of PMNs, monocyte macrophages, or NK cells. These are all processes that require the presence of antibodies in terms of the interactions with the antigen on the surface of the endothelial cells. And as nephrologists, we know that endothelial cells are primarily present on the surface of endothelial cells. Endothelial cells are primarily present in the glomeruli for the glomerular capillary loops and in peritubular capillaries. Now, let's put that in context. How bad is AMR, or antibody-mediated rejection? I will just present that in a couple of slides. Number one, from a prevalence and incidence perspective, this is one of the studies that has been largely quoted, multiple centers looking at 315 kidney transplant biopsies based on indication that determine, just profiling the changes with time, looking at it. You can see that in the early days after transplant, most of these biopsies were really not finding any major abnormalities, but with time, the primary finding was antibody-mediated rejection when with associated with disease recurrence.